The first technique is with the person prone. What you may want to do with many of these techniques is you're going to want a pillow underneath the person's abdomen. And what you're looking to do is, what we don't want is a situation where, especially when we're going to do the anterior innominate, generally what you want for these individuals is have a pillow underneath the abdomen, and that should get the pelvis and the ISS off of the table. So when we go anteriorly, there's room to move. So the first and most simplistic anterior ileal rotation is laying prone, and what you're going to do is, with your inferior hand, you're going to stabilize the sacrum with the ulnar side of your hand like this, okay? And then with the cranial hand, you're just going to come over the PSIS, and then you can start to oscillate the ilium in an anterior direction. So when you're stabilizing the sacrum, you want to be kind of near the apex with that, because without that stabilization, the sacrum is just going to want to move with the ilium as you're going through that. So with this hand, I have his iliac crest, and with this hand, I'm going to identify his sacrum, stabilize with this hand, stabilize the sacrum with this hand, and then with this hand, I can just do the anterior oscillation. If I wanted it to be a mobilization, I can lock in, get to the end range, and hold for 30 seconds, a minute, okay? Want a more aggressive anterior rotation in the prone position, what you would do instead, extend the hip by lifting with your hand here, and then what you'll do with your other hand is you will provide the anterior rotation of the ilium. Now you lose the sacral stabilization when you do it that way, but it does allow the ilium to get into further degrees of anterior rotation before you start to oscillate. Sacral rocking is we're going to be moving the sacrum. Right now we're moving the ilium, okay? So we're just doing ilium in the sagittal plane, but right now I'm talking just anterior. The second one is with the leg extension. So again, you can locate the person's PSIS, but just kind of get on that posterior 1/3 of the ilium. And what you'll do is you'll come under with your hand and start to extend the hip, feeling for how much that innominate's starting to roll, that ilium starting to move anteriorly, and once you get to the end range of that, then you can start to oscillate, or if I wanted to, it could become a mobilization technique where you hold, prolonged hold. Lose the stabilization on the sacrum, but it does accentuate the anterior ilium a little bit more, so it's just a different way of doing it. Yeah, you lose the stabilization on the sacrum when you do that. If you wanted to try to just like relax the leg on something, you could, especially if the person's leg is really large. It's probably more ideal if you can hold it yourself, but you could if you needed to. It wouldn't be slightly inferior, it would be slightly lateral, okay? So it's anterior and slightly lateral, if anything, okay? But more so, just say you can think more anterior than lateral with that. Have the person in the prone instability test position. Just step off a little bit. Yeah, and then lay on the table. Yeah, relax your legs as best you can. So if I was interested in the anterior innominate on this side, the anterior motion on this side, I can extend the leg here and then just do the mobilization there as well. Just a different way of doing that. If the leg is a little heavier, relax, relax, relax. You can hold from the knee, and that'll get you a little closer to the person as well. And then if they have that really heavy leg, you can go to using like a mobilization belt around your shoulders and their leg to help take some of that weight for you. I'm also going to show you one more anterior, and then we're just going to do just do one posterior motion manually. With the person inside lying, the ilium that you want to mobilize up top, what you're going to do is the legs are going to be flexed, the hips kind of close, almost 90 degrees, okay? And then what you can do with your hands is, with your inferior hand, you're going to get the person's ischial tuberosity, and with your other hand, you're just going to come over onto the ilium itself. So for the anterior rotation, what you're going to want to do with your hand is you're going to want it to face this way. That way, what you can do is you mobilize the ilium anteriorly. So this hand is kind of given a superior posterior motion, while this hand with the elbow this way is trying to pull the ilium anteriorly. So both together, I'm creating this anterior motion. Anterior ilium and sideline, it's another one. So you've already done 2 ways to do the ilium anteriorly. I just showed you a 3rd way. This is a 4th way to all do the exact same technique. For the anterior rotation, so my hand's on the ilium here, posterior ilium. In fact, the PSIS is almost like right at the base of my hand, right there. That's where I have my hand there. And then this one, my inferior hand's just on the ischial tuberosity here. And then what we're going to do is we're just going to try to rock the pelvis anteriorly. I can oscillate. Associated with hip extension. So if I wanted to accentuate it, I could ask him to maybe like straighten out that leg back, but I'd want that supported. You can see the hip adduction's not good. So like if you look at the textbooks and stuff, the hips are still just kind of in a neutral position. The posterior rotation and sideline, instead of fixating my hands to create a anterior rotation, I'm going to switch my hand around to create a posterior rotation. Okay, so now my hand is on the anterior portion of the iliac crest, the cranial hand or the superior hand, pushing posteriorly, while this hand is on the ischial tuberosity, creating that motion that way. So kind of anterior superior. For this one, especially for the posterior rotation, we know is associated with hip flexion. So it's a good idea to even have the person's leg and have that leg flexing with you as you're doing that process. For the posterior innominate rotation, this one I always liked to have the hip going with me into flexion, because that's going to be associated with the posterior rotation. So instead of my hand being this way for anterior, it's going to switch around. So now I'm on the iliac crest forward. I'm on the ischial tuberosity this way. And then what I can do is I can do a combination of hip flexion and just move my hands to create the posterior innominate, or the posterior rotation. It could be an oscillation, or it could be converted into a mobilization. So this is an exercise technique, and so what we're going to do is we're going to use the pull of the surrounding muscles to facilitate the ilium to either anteriorly rotate or posteriorly rotate on itself, okay? So which muscles, if we were going to contract them, would be most ideal, or what one muscle in particular would be really ideal to contract to pull the ilium anteriorly? The iliacus, very ideal. Yeah. Why is it the ideal muscle? It physically attaches to not just what, like a small part like the AIIS that the rectus femoris does, but very broadly to the entire anterior surface of the ilium. Plus, its action is right there at the joint itself. So what we do and what you see clinically is an isometric hold into hip flexion. I'm sticking to the iliacus because the psoas doesn't attach to the ilium. We wouldn't expect the psoas to help assist with pulling the ilium so much anteriorly. But the iliacus, when it contracts, it's going to attempt to flex the femur towards itself and approximate, correct? But in an isometric hold, if we're not going to allow the femur to move and the iliacus is contracting stronger and stronger, what's it going to do to the pelvis? Something's got to move. I'm contracting, I'm getting shorter. These two bones have to come closer together somehow. So you get that anterior translation or anterior rotation of the ilium. What about the posterior rotation of the ilium? What muscles would be really good for posterior translation of the ilium? Hamstrings could be good because they attach to the ischial tuberosity, okay? But what's a better, broader muscle that attaches to the ilium? Glute max, especially, right? That muscle would contract really hard. It would pull on that portion of the ilium. It would pull on this portion of the ilium and backwards, okay? So again, we're going to isometrically hold the thighs while the person performs that, okay? And the way you do that, if you're going to be the therapist and assist with this, all you're going to do is you're going to teach the person first to, what I want you to do is flex this leg up while kicking this one down at the same time, and you just offer that resistance and relax. Now, there's a couple of things you can do here. You can just have the person repeat that several times. Go ahead. And again. Relaxing again. So in this one, she's anteriorly, her right innominate's anteriorly rotating while she's posteriorly rotating the left, okay? And then to do it to get the opposite, you just switch your hands and then have the person engage those muscles, okay? Now her left innominate is going anteriorly while her right one is moving posterior. This is something you can teach your patient to do for themselves as a home exercise program. Is fantastic because all you're going to ask the person to do is with one hand hold here, and with the other hand just simply grab around the back of your leg. And then what you're going to do is just pull against those at the same time. Don't allow your legs to move. Educate them on how hard we want them to contract, how long we want them to hold those contractions, and how many times, okay? If we were looking for more mobilization, we might tell the person to hold a little bit longer. But if we're looking for just a joint oscillatory effect in the region that a person can do for themselves at home, you just have them hold for a second, maybe two at the most, and just repetitively do those contractions again and again. So that's the exercise for the anterior posterior ilium. The person sitting in a chair, they could have one hand on top of their thigh, lifting that leg up while pushing their other leg down. So you can do these in different positions. We're done with sagittal plane. Now we need to get the ilium moving in the transverse plane, okay? And the first muscles we're going to talk about is so we're talking about outflaring and inflaring the ilium now. That's what we're trying to do, okay? So which muscle or muscles are in a very good position to help pull the pelvis into an outflare? What muscles are on the side of the hip there that are, if they were to contract, might be able to pull that pelvis out somewhere? The glute med and min, they're abductors, correct? All right, so TFL is very good at this too because it's right there. So if we can get all of them firing at the same time. So when you think about the exercise for the transverse outflare, hip flex 90 degrees, and just have them isometrically abduct into your hand, as the other side, to get that muscle contraction. So once again, the thigh wants to come out, but we're not allowing it. So instead, the muscles start to pull on the ilium outward. A muscle contraction for the inflare is once again the iliacus, because it's the muscle that's there. But we got to change its line of pull slightly. If we just do it here, we already said, no, Dr. LaRosa, it's going to actually pull. How's it going to immediately pull now? So the way it's suggested you do that is with the leg that you're going to exercise, provide adduction and place the hip in about 45 degrees of flexion, not 90 degrees anymore. So what we're going to actually do is we're going to change the leg position. And just relax your leg there for a moment. So we're more in this position. And now the iliacus is pulling this way, because I changed where the position of its insertion is in relation to where it is anatomically on the body.